Okay, so we have a patient here with like more than 6 months pain in his back, low back, and radiating into the right leg, on the back side of the right leg. So it looks like a S1 distribution. On the MRI, we have found L4, L5, and L3, L4, and L2, L3 protrusions. The most significant is at L4. L5 level, where it's like a significant extrusion without any attack of the S1 nerve. So we don't know 100% what is his correlation between his MRI pictures and his clinical symptoms. That's why we have decided to take away the deherniation by transforaminal approach. But because his clinical symptoms are dominantly from L5 S1 level, most probably at the S1 on the right side, we would like to do epiduroscopy. We would like to check how the epidural space looks like, and then we will make the final decision for his final treatment. First step is to put the local anesthesia at the incision point, at the level of sacral hiatus. You do it in lateral projection on your C-arm, and everything is going under C-arm control. So the first step is you're going with your needle to the sacral hiatus, checking where you are, and then you're trying to achieve the angle which is no more than 45 degrees, just because your target is anterior epidural space. So you're infiltrating the local anesthetic, and with a local anesthetic needle, you are actually also checking the angle and the trajectory of your epiduroscope for the next step. So this is the first step. You inject local anesthesia. The patient is awake. It's the best neuromonitoring. The second step, and this is a little bit unusual for pain physician from time to time, you can use Seldinger technique. That is one option, but the epiduroscope we are using today is without Seldinger technique. So what I'm doing is a surgical technique instead. So I take a surgical knife and I go the same trajectory as I done before with a needle, and then what I'm doing is I'm approaching the sacral canal the same way. Third step, which is use of surgical forceps to lift up the sacrococcygeal ligament to be able to go inside to the sacral canal with the epiduroscope itself. Now I'm taking out the knife, I'm taking the surgical forceps and going inside with that, with the face down of the surgical forceps. Okay, and now I'm rotating the forceps with the face up and lifting up the sacrococcygeal ligament. I can do it a little bit like the sides as well, just to prepare the correct position for everything. The final step is going inside with the scope. So as I said, we are going inside with in a lateral position, we're going inside with the epiduroscope, and we are just going to the first part of the sacral canal. We're checking in a lateral position, we see that we're okay. Now we know where we're going. We would like to go maybe above the L5 S1 disc, or mainly even up to L4, L5 disc herniation. And what we would like to do is, we would like to do this in an anterior epidural space. But also, because his pain is on the right side, we would like to see if we're on the right side right now or on the left side. So we need AP projection to have a look where we're aiming from the very beginning. So we're going to check the direction of the epiduroscope regarding the site, and what we would like to have is aiming to the right side. So now we can we can have a look at the epidural space itself. As I said, it's posterior epidural space. So we're starting from about the L4, L5 lateral recess, slowly. The picture is because of we're quite in a small space. You see a little bit of vascularization, a little bit of epidural fat. We're slowly going lower down, and now we're getting the picture of disc level, but we are in posterior epidural space, so you don't see anything else except for dural sac right now. You see the dura, which is nicely vascularized without any pathological changes. So we carry on, posterior epidural space, go down, and then I check where we are. So now the patient is reacting a little bit here at this level. Now you see a little bit of hypervascularization and a little bit of inflammation. This is about the level of L5S1. And here you see at this level we have some adhesions, adhesion tissue. This is this white tissue you see, which is not robust, but anyway, there is some kind of pathological tissue at this level, and you never know if this can cause any irritation of the nerve root or not. We carry on. I'm now inside the sacral canal and slowly coming to the level of a little bit of adhesions to the level of S1 nerve, which can be the problem because of clinical symptoms. I have some kind of hypervascularization with the epidural fat here. Checking here, epidural fat, which is a good sign. And it's a little bit of inflammation and a little bit of bleeding here. But it also doesn't look like a significant problem. And as I said, we are still in a posterior epidural space. So we have checked the posterior epidural space without any significant findings. If we found something, we could give a cortisol injection, for example. If we found some adhesions, we could take care of adhesions with a radio frequency probe. We're now nicely in anterior epidural space, and what we need is to achieve the anterior epidural space at the level of S1, because we don't have a correlation on MRI between S1 radicular pain and between L5S1 disc herniation. So I'm trying to push the direction of the scope downwards, and I'm trying to push the epiduroscope towards the S1 canal, which is going well. And you see here, there is clearly some kind of inflamed dura. So for some reason, this red structures, red color on the dural sac with adhesions is showing us some kind of evidence that something at this level is wrong. And that's why it's maybe wise to give some kind of treatment for this level. So here we are at the level. You see a beautiful picture of like a varicose vein at the epidural space, which also means there is some pathology. So the blood vessel there is significantly wider than it's supposed to be, and it just giving the information that something at this level is wrong. We see dura above. We see a very nice picture of the epidural space at this level. You can also use this technique if, for example, you have a disc herniation which is going with a cranial propagation behind the vertebral body from one level down to the other level, and you are not sure that you have taken all the herniation outside. You can take epiduroscope, and at the end of the surgery you can have a look if everything is extracted. I carry on. Nothing special here, no bleeding. You have also a possibility to check through whole way down if there is any bleeding, and if there is no bleeding, you know that you are not supposed to expect any epidural hematoma. Slowly coming out, and we are finishing the procedure.